Good morning, Team Gyan 6 for providing me this opportunity. In my previous session, Rahul sir and Dr. Indrajit has explained so well about the upper eyelid anatomy and its surgical approaches. In my presentation, it would be a bit of repetition of the surgical anatomy because most of the things have been already explained by Dr. Indrajit in the best possible way. I will be focusing more onto the lower eyelid and I will directly correlate with the applied aspect rather than going much into the anatomical aspect. Okay, now if you see the sagittal section of the lower eyelid, these are the areas which we are going to encounter from if you go from anterior to posterior. First one is the eyelashes, then followed by the skin and subcutaneous tissue. The third layer is going to be orbicularis oculi muscle. Behind that there would be tarsus plate followed by orbital septum, it's in continuation, and the conjunctiva. Now eyelashes, Dr. Indrajit has already explained there will be nearly 2 to 3 rows of eyelashes. In the upper eyelid it would be nearly 100 to 150 hair follicles, while in the lower eyelid there would be nearly 50 to 70 eyelashes. Now these hair follicles would be like in an upward and outward direction and they are not interlacing. This is one of the most important tissue, skin. It consists of epidermis and the very thin layer of dermis, which has got an extreme elasticity. So whenever we are carrying out the lower eyelid approaches, we need a good amount of traction for the better exposure. So in most of the cases, skin is extremely lax, so we get a good superior retraction or inferior retraction with the skin hooks or with the Brolin 60 sutures, which give a good retraction and surgical exposure. Second thing, skin is extremely loosely attached to the underlying orbicularis oculi muscle. So that is also very helpful. In one of the videos, Sonal ma'am has already shown the things of hydrodissection. So whenever we inject the local adrenaline, local anesthesia with adrenaline, we inject in a subcutaneous plane. So it is a large plane and it has some volume. So local anesthesia will get deposited and it creates a surgical plane. So hydrodissection has got a extreme importance whenever you are considering subcutaneous approaches of the lower eyelid, because relatively large quantity of fluid may get accumulated within the subcutaneous tissue. Now orbicularis oculi, it has got two parts, orbital part and the palpebral part. Orbital part is relatively thicker fibers and the palpebral part has got two subdivisions like preseptal fibers and pretarsal fibers. There is also one small lacrimal part, that is pars lacrimalis, which is again in a part of the orbicularis oculi muscle. Now this muscle has got extreme importance when you are considering subcutaneous approaches, especially subciliary approach and subtarsal approach. Now if you see this particular slide, in the subciliary approach, the orbicularis oculi muscle is being divided in two different ways. One is it is being skin and subcutaneous tissue dissection has performed and undermining has been done up to the infraorbital rim region, and then the orbicularis oculi muscle is being divided. In the another way, in subtarsal approach, the orbicularis oculi muscle is being divided almost at the halfway from the eyelashes to the infraorbital rim region. I think detailed approaches will be discussed by Dr. Rahul sir in an upcoming presentation. Now if you see the cross section, the anteriormost aspect is the skin, just posterior to it the pink color attachment is the orbicularis oculi muscle, just posterior to it.
Pratik, use the cursor.
Yeah.
No, the cursor, not the pointer.
Okay, yeah.
Yeah, thanks.
Okay. Okay, now if you see the sagittal section, the most anterior aspect is skin. Just behind that there is the orbicularis oculi muscle, and on top of it there is a tarsal muscle. Now we are talking about tarsal plates. There is a superior tarsal plate and there will be an inferior tarsal plate. Now the length of the tarsal plates is roughly 29 millimeter mediolaterally. If you talk about width, in upper eyelid the width of the tarsal plate is somewhere around 10 to 12 millimeters, while in the lower eyelid width is around 3 to 4 millimeters. Both these tarsal plates, medially they are attached to the medial canthal ligament. Eventually it gets attached to the medial orbital rim, and laterally they are attached to the lateral canthal ligament, which in turn gets attached with the Whitnot's tubercle laterally. Now if you see the second slide, I have retracted the tarsal plate with the skin hooks. In the transconjunctival approach, whenever you are placing the incision has to be from medial to lateral to medial, and it should be at least 2 to 3 millimeter away from the tarsal plates, just to prevent damage to the tarsal plate. The next is orbital septum. Now again, this is a very important landmark. Just posterior to muscle, there will be orbital septum, as Dr. Indrajit has already explained. Now this orbital septum, basically it is in a continuation of the orbital periosteum. It creates a diaphragm between face and orbital contents. In the second slide, if you see, in the transconjunctival approach, we have raised the cranial conjunctival flap, which contains the orbital septum, and eventually it protects the eyeball itself. So apart from the corneal protection shield, this would be the second thing which is going to protect your eyeball. So whenever you raise a cranial conjunctival flap along with the orbital septum, it is going to protect your eyeball.
Pratik, cursor.
Yeah. So this is its slide is getting changed actually. Yeah, so this is a cranial conjunctival flap which is containing the orbital septum here, and this is a orbital thin. It's very in the medial section. It is a very fragile section. It's a very fragile section which is covering the orbital contents. Now this is again an important slide. If you see, in the orbital septum, if you are considering any transconjunctival approach, there will be two approaches. One is the preseptal approach and the second one is the postseptal approach. In a preseptal approach, whenever you are putting an incision onto the orbital ring, it has to be in front of the orbital septum. Here if you see, this is a orbital septum. If you can see, this is the orbital septum. Just posterior to it, there is an orbital fet. So whenever you are going for the transconjunctival preseptal approach, the periosteal incision is placed just 2 to 3 millimeter below the infraorbital rim to reach the infraorbital rim and floor of the orbit. If you are going for the postseptal approach, you have to place the incision posterior to septal, and in that case you will encounter the orbital fet as well when you are going for the postseptal approach. Now that's the palpebral conjunctiva. That's the one of the also very important landmark when you are considering the lower eyelid, and this is most important landmark when you are considering the conjunctival approaches. In subcutaneous approach, you don't much encounter with the conjunctiva, but if you are going through the conjunctiva, that's a transconjunctival approach, you have to consider this landmark very importantly. Usually whenever you are placing incision in transconjunctiva, again as I repeat, the incision has to be at least 2 to 3 millimeter away from the tarsal plate. You can clearly appreciate here it's a tarsal plate. That's a pink color part, that's a palpebral conjunctiva. Your incision starts from lateral to the medial, and when you start, it has to be divided from lateral canthal ligament towards the medial it should go. Now this palpebral conjunctiva is being attached to the inferior fornix, and from inferior fornix it is being continuated as a bulbar conjunctiva. Lateral canthal ligament, yes, both the tarsal, superior and inferior tarsal plates, laterally they are inserted into the lateral canthal ligament. It's a Y-shaped ligament which is getting inserted laterally to the periosteum of the orbit, at times 2 to 3 millimeter posterior to the orbit and Whitnot's tubercle. Now if you see, whenever you are considering lateral canthotomy and cantholysis, you need to divide this lateral canthal ligament. So what happens, as soon as you divide the lateral canthal ligament with lateral canthotomy and inferior cantholysis, the lower eyelid is going to get retracted in a more inferior fashion, so you will have a better surgical exposure, and moreover whenever you are dividing the conjunctiva, you will have a better access to divide the conjunctiva from lateral to medial way in a most inferior retracted manner. Now one more muscle which has got utmost importance, that's an inferior tarsal muscle. Now I show you in this slide, these are the tarsal plates. If you see, this is the inferior tarsal plate, this is the orbicularis oculi muscle, this is the orbital septum, just posterior to it there is an orbital fat, and below that there is an infraorbital rib. Now inferior tarsal muscle, it is somewhere over here. It arises from the inferior rectus muscle and gets inserted to the inferior tarsal plate. Now why this muscle is important? When we are extending the conjunctival approach to the caruncular approach, you need to approach the medial orbital wall. So whenever you are going towards medial orbital wall, you need to divide the caruncle, and your plane of dissection should be just posterior to the Horner's muscle, that's called as inferior tarsal muscle, and between the Horner's muscle and the orbital septum. I will show you. This is the orbital septum over here, and this is the Horner's muscle. This is the medial orbital wall. So whenever you are extending your incision towards the medial wall of the orbit, your caruncular is divided and plane of dissection should follow between the Horner's muscle and the orbital septum to reach the medial orbital wall. Now coming, the next is medial canthal ligament or medial canthal tendon. Again, that's a very important structure. Medially it is associated with the tarsal plate, and laterally it is associated with the tarsal plate, and medially it is inserted just anterior lacrimal crest and towards the posterior lacrimal crest. In between this anterior and lacrimal tendon, there is a lacrimal sac which also contains the lacrimal canaliculi, and eventually this lacrimal sac which opens into the nasolacrimal duct and it goes into the inferior meatus. Now again, medial canthal ligament has an importance because if you are extending your incision towards the caruncle region, your incision should be posterior to the medial canthal ligament. I mean, it has to be posterior to the posterior lacrimal crest just to prevent injury to the lacrimal sac. Here is the medial canthal ligament, that's the lacrimal sac, which is in continuation with the nasolacrimal duct, which in turn open into the inferior meatus. So whenever you want to expose the medial orbital wall and your incision is being extended medially, make sure periosteum should be incised posterior to posterior lacrimal crest just to prevent the injury to the lacrimal sac over here. That's a nasolacrimal system as I described. Now what are the important anatomical landmarks? If you see here, there are a couple of foramen. That's an anterior ethmoidal foramen, that's a posterior ethmoidal foramen, and that's the optic nerve. Here if you see, this is a anterior lacrimal crest and this is a posterior lacrimal crest. Between this anterior and posterior lacrimal crest, there is a lacrimal sac. Now the distance between anterior lacrimal crest and the anterior ethmoidal foramen is roughly 24 mm. Then it goes to 36 with the posterior ethmoidal foramen and it goes to 48 with the optic foramen. So what happens if you are extending your incision medially? You can reach up to the medial orbital wall, and at times with the caruncular approach you may encounter the anterior ethmoidal blood vessel. So you need to protect these vessels, or you need to ligate when if you are going towards the medial orbital wall. Arterial supply, Dr. Indrajit has already explained. Medial and lateral palpebral arteries which are being supplied to the upper eyelid and lower eyelid. Lateral palpebral artery, which is in turn is a branch of the lacrimal artery, which is again a branch of the ophthalmic artery, which is a branch of the internal carotid artery, and medial palpebral artery, which is an indirect branch of the inferior internal carotid artery. Medially it is being supplied by the angular artery, which is a branch of the facial artery. Venous drainage is mainly from the ophthalmic veins. And nerve supply, if you talk about the lower eyelid especially, the motor nerve supply is being supplied by the facial nerve, while the sensory nerve supply is being supplied by the infraorbital nerve, which is the first division of the trigeminal nerve, and the infratrochlear nerve. Regarding lymphatic drainage, the lower half of the medial aspect of the lower eyelid is being drained into the submandibular node, while upper eyelid and lateral orbitally it is being drained into the preauricular and parotid lymph nodes. Now I'll just show you a couple of landmarks with this particular video. Details will be definitely being shown by the Rahul sir. It is just the purpose is just to show the couple of landmarks. If you can see the conjunctiva which is being held by the Prolin 60 suture, and the incision was placed from laterally to medially, and this is a cranial conjunctival flap which, if you raise it cranially along with the orbital septum, it protects the eyeball. So with the spoon you can lift the entire content superiorly and it protects the eyeball. So this is a conjunctiva which is containing the orbital septum. If you see in this particular video, the incision is being placed from laterally to medially after canthotomy and cantholysis. If you notice, the tarsal plate has been retracted in the inferior direction and the incision is placed into the conjunctiva which is just 2 to 3 mm away from the tarsal plate, just to prevent the injury to the tarsal plate. Yeah. Now what's the take home? We need to select the surgical approach is based on the anatomical area involvement. We should have a sound knowledge of orbital and periorbital anatomy before stepping into transconjunctival approach, because it has got a bit of learning curve. Training, infrastructure, surgical assistance, years of experience and level of confidence also become the deciding factors at time for selection of which surgical route to be considered. Thank you.
Thank you very much, Pradeep. Excellent.